Hello. This lecture or discussion will cover the remaining content from the community and cultural diversity section of our course. So, picking up where we left off in class, moving on to cultural diversity, just addressing some of those definitions of what diversity means, and that's that mixture of a variety of groups that are either grouped together as sociodemographics, belief systems. We know that there can be things that are even diversity in age and gender as well. Culture, it's that worldview that comes from a set of traditions or from a belief system of a group. And then cultural diversity, when we move these things together, it's those differences that exist among all peoples that are connected to the cultural conditioning that has been present as they live and move about the world. Getting back to 2020 National Health Goals, which we already touched base on in class a little bit, you can see listed here and again throughout your textbook that there's a big focus on prenatal health care and meeting adequate needs of the client who needs prenatal health care. There's also a big focus on increasing not only the number of women who elect to breastfeed, but then maintain breastfeeding. And then also looking at full-term births and the reduction of SIDS. Vaccinations are always included on that list and have been since we've started National Health Goals. Suicide rate extends beyond there, especially in our adolescent population, since we're talking about maternal child health. And then the rising incidence of mental illness and how we manage mental illness. So again, tying it back to what we do as nurses, we look at and we contribute to those programs that exist that help us meet these national health goals. We do that in a way that's always culturally sensitive, and we always plan our care directed to the groups of individuals that we know we're specifically delivering that program to. And you'll see in chapter 2 that the role of the nurse in the community, and then with specific community members, especially the LGBT population, we're increasing our awareness of those unique needs that are needed. In particular, you're directing you to your textbook. Your authors discuss the very unique situations for the LGBT community, and that there's the increased level of stress and victimization, and they this can be interpreted in higher rates of alcoholism and higher rates of suicide attempts. I'm not certain that your book delineates that it's persistent throughout a lifetime, but that we must at the very least recognize that there could be increased stress levels due to the isolation and victimization of what is coming up for the LGBT or for the gender disoriented client. So as we look at our patients, we look at them as individuals, but we do recognize the group that they may belong to. So there's a difference between recognizing risk and avoiding stereotyping. And I think that it's important that you yourselves as future nurses look inside yourself and really try and separate out what that means when I say that. Stereotyping is when you make an assumption based on someone's culture, appearance, of who they're going to be. However, when we look at cultures, whether that be race, ethnicity, cultures, even like the LGBT population, we know that there are specific risk factors that are associated with culture, ethnicity, and that is not stereotyping. That's recognizing those phenomenological things that happen amongst cultures. Now, of course, we always put aside prejudices. Prejudice is a view that we maintain that may inhibit us to openly caring for any individual regardless of their culture. And we are never to discriminate as nurses. Now, there are a couple of videos embedded throughout this presentation. I'm not going to click on them and let you do that. They're great. You're going to find that these videos are funny, they're brief, and they talk about not only communication and culture, but also you'll see that a couple of the videos talk about what some of our body language might mean in other cultures that might be different from here in the American westernized culture. So communication is really important to recognize, because we know that not only first and foremost language, right? Language barriers can be an issue when we work with a client when we don't speak the same language, but we also recognize that even the way in which we communicate, who we communicate with, family members, roles within the family can be quite different culture to culture. And we recognize that some cultures might feel insulted if we talk about certain things or the way we look in the eye, and there's so many variables to consider. Do keep in mind that if you have a language barrier with a client, the proper way, the right way within the scope of nursing to address that is the use of an interpreter. We should not be using family members as a legal interpreter. We should be requesting the assistance of a live interpreter or the many different interpreting services that are provided in our local community hospitals, such as interpreter phone lines or different website programs now that also exist. So when we look at communication, we take into consideration the capability of the client we're working with. Can they read? Can they hear us? Can they see? Do they have a visual disadvantage? And we always want to make sure that regardless of the individual working with, that we're always direct, avoid lengthy explanations, and keep it simple without slang. Mindful of nonverbal cues like rolling our eyes or, crossing our arms can sometimes look like we don't want to talk to the client. And again, another video has been embedded for you here to just kind of, it's kind of a spoof on communication, but you might enjoy it just to see, like, have you ever thought about the different ways of communication? So cultural practices, when we talk about real delineating things that we see culture to culture that might be different, might be in any of these that you see on your screen. How we respond to pain, how we value time, what's the role of a male and a female can vary tremendously from culture to culture. What's religion, spirituality, these are all variables within each culture. Doesn't often define the culture. Remember, the culture is the worldview, but these are things that can be measurable that actually vary from one culture to the next. How to maintain health. How do I receive health care? What would be appropriate health care? What can I not receive? And then our nutritional practices and even awareness of how healthy we're living. A great example of cultural variables, worked for many years with a former colleague right here at our own college, and she grew up in the Caribbean, and she's a dear friend, dear colleague. But we used to have, and we joked about it, because I would say, listen, we're not going to do this on island time. Because sometimes, like, her perception of time and my perception of time was very different. So I would say we should get this done immediately, but immediately had to be defined sometimes. She's like, okay, so maybe next week. No, immediately to me, especially in the American world, right, is it happens right now. So, and yet another video to help you kind of bring communication and culture together and understanding why that's important. So the reason why there's a lot of coverage in your chapter and this PowerPoint about the LGBT culture is because there was very few questions in the test banks about LGBT sensitive training and cultural awareness. And in the last 10 years, we as a society have certainly opened the door to what I hope for all of my loved ones in the LGBT community is equality and access to health care without any kind of fear of isolation or discrimination. So the questions have, it's kind of, it's been a hot topic, right, in our news and our culture and our political world. So therefore you will find that there are more questions on the LGBT community. And again, keeping in mind that from their perspective and their lens, that client may still feel as though there's discrimination that exists, and they may be frightened to seek the health care that they need. And you can see it right there. We do have a higher rate of stress-related disorders in our LGBT population. So it's important that our clients understand that we are open, accessible, and deliver sensitive care without stereotyping, of course. So maternal child health, bringing it back to this course, OB and pediatric care in the community, it really starts with the family. So different from the public health nurse who's looking, who's looking at the community at large, the public, when I'm a maternal child health nursing role, I'm looking at families and what's happening within the family and what things places the family at risk. And from that point, when I connect myself to the community, I am able to not only advocate, counsel, and advise, but be mindful of the services that exist in the community that can provide help in any area that seems to be at risk. A great example of a number of examples exist, but some of the obstetric and then pediatric examples might be Women and Infant and Children's, or the WIC program here right in Massachusetts, where I know that I can make referrals for low to moderate income women to get adequate sources of healthy nutrition. And at the same time, they'll also get nutritional counseling and lots of other resources come out of the WIC program. Early intervention is another community program pediatric nurses are very familiar with, and that is that for any child who's at risk for not meeting developmental milestones, this would be a wonderful resource for the family. When we talk about community programs and initiatives that happen, going back to former semesters, just kind of refresh your memory about what a primary level of prevention is, a secondary, and a tertiary. Primary is all about promoting health, promoting education, promoting awareness, and preventing illness. So it might be something like mass vaccination, counseling women about the importance of mammography beginning at age 40, those kinds of things. When we talk about a secondary level of disease prevention, we're talking about actually taking those folks who are high risk and actually diagnosing and treating those folks. So picking up the high risk. Primary is we capture large numbers. Secondary is we capture those that we know and anticipate this could be a problem. And tertiary is we're designing programs that will rehabilitate the client who has a need for restoration or end of life. I'm going to stop here and do part 2 next.